We're here in Madrid at EAU with Professor Van Poppel from Leuven. Professor Van Poppel, thank you for joining us. You just shared a session about bladder cancer. What are the highlights in this field?
We had a very nice plenary session this morning on bladder cancer, and there were a couple of issues tackled. The first was on lymph node dissection. I think it is clear to everybody that a patient who has a muscle invasive bladder cancer, and certainly when he has locally advanced disease, T3s, that these patients should all have an extended lymph node dissection. So no way to do the standard limited lymph node dissection. And I think it's very clear from open studies, not from randomized studies, that this is now the general rule and the guideline that all bladder cancer patients should have that. Another presentation that was interesting was from the upper tract urothelial cancers, presented by Sharok Shariat, and again it's actually about the same, and we believe that if you have T2, T3 tumors in the pelvis or in the upper tract in the ureters, that also these patients should have a lymph node dissection. So it's not wise probably to do a quick and fast laparoscopic radical nephroureterectomy, but these patients need to be completed with a lymph node dissection, of which there was a proposal on how the templates should be for pelvis, should be for the mid-ureter and for the distal ureter. So I think these were absolutely two fantastic contributions.
There was a very interesting session yesterday of the European School of Oncology. Could you tell us a little bit the conclusions of this session?
This is actually a very special formula. It's a very special way that the European School of Oncology is organizing this so-called observatories. What they actually do, they've done it in colorectal cancer, in breast cancer, and since 2 years we do this now in prostate cancer as well. So they ask 5 experts and the patient what they believe is going to be the new things in prostate cancer in the coming year.
Your conclusion is multidisciplinarity?
Multidisciplinarity is the way to go, and I think the ESO and the ESU, where I was director of for a couple of years, we really realized that cancer in general, prostate cancer, kidney cancer, bladder cancer, this is all multidisciplinary business and not just the task of the urologist. The urologist should take the lead and should be the coordinator and is the one who is finally guiding the patient, but we need to work in multidisciplinary teams and consultations.
Okay, Professor Van Poppel, I thank you very much.